previously worked at the NIFDS as vaccine reviewer. Now I am responsible for managing vaccine safety at KDCA. And then 2022, I also served as an on-site reviewer for the WHO-listed authority assessment on vaccine pharmacovigilance. Since I have also experienced being reviewed by WHO, I understand both the importance of WHO designation and the pressure that regulatory officers may feel during the process. When I was invited to give this presentation, I thought deeply for a long time about what would be most helpful to share. Finally, I decided to base this presentation on my own experience preparing for GBT and PE, understanding the different perspective of regulatory authorities and public health agencies on pharmacovigilance, and responding to the WHO evaluation team's inspection aspects. Using this experience, I will introduce Korean National Immunization Safety Management System and share insight from the WHO performance evaluation. Now I would like to talk about the national immunization policy of Korea. The KDCA is a national public health institute responsible for investigating and researching infectious disease. It is organized into 8 departments and 41 divisions. Within the Department of Healthcare Safety and Immunization, the KDCA manages vaccination program, vaccine procurement and supply, and oversees vaccine safety management. In red text. In Korea, vaccination began in 1954 based on the Infectious Disease Control and Prevention Act, which authorized the local government to conduct vaccination for 7 infectious diseases. Over time, as diseases were removed from the list, the program expanded. Currently, vaccination are provided for 19 infectious diseases, and when necessary, such as during outbreak of COVID-19 or mpox, temporary vaccination are also implemented by designating them as infectious disease requiring immunization. In Korea, vaccination for which the government designates the vaccine types and target population and provide the financial supporting are called a national immunization program. For example, vaccination against the herpes zoster is available in medical clinics, but it is not included in the NIP. For such non-NIP vaccines, pharmacovigilance is conducted by the MFDS. KDCA plans the national vaccination strategies and budget, develops and distributes guidelines, and provide a mandatory training program for vaccination officers. Finally, last, KDCA also established the overall vaccination infrastructure. For example, during the COVID-19 vaccination campaign, KDCA set up vaccination centers based on vaccine supply and storage capacity to find the target group and ensure that most citizens could be vaccinated quickly to overcome the pandemic. Municipalities implement the vaccination program at the local level. Local officers complete the vaccination training, develop detailed implementation plans, signs contracts with the medical institution, and provide financial support after vaccination is completed. Healthcare facilities complete the required training, conducted vaccination, and record all vaccination data in the National Information System. Public health centers and healthcare facilities administer the vaccines to recipients. The NIP is complete when all institutions fulfill their respective role. Now I would like to talk about immunization safety management system. The KDCA manages vaccine safety through 4 main stages: adverse event, surveillance, epidemiological investigation, and rapid response to serious case, vaccine injury compensation, and causality assessment for result feedback. More detailed information for AE, the KDCA operates both passive and active surveillance system. In the past, passive surveillance reports are received from healthcare providers or vaccine recipients. In the active surveillance, text messages are sent to vaccine recipients to guide them on how to report AEs. And then health insurance data are analyzed to detect possible AEs by KDCA. For feedback, KDCA shares vaccine safety information with the local governments. This includes notifying them of causality assessment result and providing alerts on specific conditions that require monitoring, such as thrombosis with thrombocytopenia syndrome or myocarditis after COVID-19 vaccination, and herpes zoster after varicella vaccination. The management of AEFI is carried out in accordance with the national law. This slide shows the relevant legal basis for each activity. First of all, AEFI surveillance. When a physician, dentist, or Korean medicine doctor diagnoses an AE, they are required by law to report it. In addition, vaccinees or their guardians may also submit a report if an AE occurs after vaccination. Second and third, epidemiological investigation and rapid response. When a serious event such as severe illness or disability or death occurs after vaccination, KDCA and municipal epidemiological investigator conduct an investigation. The vaccine injury investigation committees then review the preliminary causality assessment and may recommend acts such as a suspension of vaccination. Third, epidemiological investigator system. To assess causality between vaccination and the events, epidemiological investigators are deployed. These investigators are selected from professionals with background in medicine or public health or biology, and then they are appointed after completing mandatory training and evaluation. The last, vaccine injury compensation. If an AE determined to be related to vaccination, the National Vaccine Injury Compensation Committee reviews the case. The government provides compensation to the affected individual. In all compensation cases, an epidemiologic investigation is conducted, and then the Vaccine Injury Investigation Committee performs the causality assessment. This slide is about to explain 2 cases of commit. On the left, the Vaccine Injury Investigation Committee. The Vaccine Injury Investigation Committee examine the causality between vaccination and AE. Causality is determined based on medical evidence, so the committee is composed mainly of medical experts in vaccination and infectious disease. To the right, National Vaccine Injury Compensation Committee makes decision on compensation. In addition, medical expert, it includes representatives from civil organization and legal experts to ensure that both medical and police perspectives are considered. Both committees meet 4 times a year on a regular basis. However, when a serious AE occurs and rapid action is required, the Vaccine Injury Investigation Committee holds an emergency meeting to review the case promptly. For this slide about AE surveillance, this slide shows an overview of the AE surveillance system in Korea. As mentioned earlier, when an AE is reported, is reviewed in sequence by the public health center, municipal authorities, and finally by the KDCA. When a medical professional diagnoses an AE or certify a death related to vaccination, they can report it through the Integrated Disease and Health Control System, which include the AEFI reporting system. In addition, to make the safety monitoring system more accessible, vaccinees or their guidance can also report AE directly through the National Immunization Program website. This slide is about the system which is the AE reporting system. When an AE is reported by a vaccinee, guardian, or healthcare provider, the case appears on this system, this right side. In some cases, when a report is submitted directly by a vaccinee, the information may be incomplete, such as missing detail about the AE or the vaccination information. In such a case, the public center reviews the report and correct the detailed information on the right on the screen. For severe, the public health center reviews all reports submitted by vaccinee or healthcare provider on daily basis. If a case is determined to be serious, it is entered into the system for further actions. The municipal authority and KDCA then share and review the information together to ensure a coordinated response to the severe AE. This part is more detailed information. When a severe AE occurs or when an epidemiological investigation is conducted for vaccine injury compensation, investigation check whether the event may have been caused by vaccine quality issue or whether similar events were reported among people who received vaccines from the same lot number. Usually about 20 to 30 recipients are investigated. The review focuses on those vaccinated at the same time medical institution on the same day, and it is also includes vaccination administered up to 1 month earlier or within the same local area. If clustered AE are identified in time or in location, this serves as important evidence for deciding whether to suspend vaccination temporarily. The epidemiologic investigators upload their investigation reports into the system so that all relevant officials can review the result in real time. This process enhances efficiency and transparency in managing vaccine safety. This slide summarizes the points by the text. This slide is about epidemiological investigation and rapid response. Vaccine is related to vaccine errors, vaccine storage condition, or the underlying health status of vaccinee. If AE are identified in a specific time or location, this provides evidence for deciding whether to suspend vaccination temporarily. When a severe AE occurs, it may be due to an underlying disease or a vaccine-related causes. In such case, the Vaccine Injury Investigation Committee is convened promptly to review the case and assess causality. This slide summarizes the main role of responsible officers, which will be explained. This slide. Here you can see the detailed responsibility of each level involved in vaccine safety management. Public Health Center conducts the initial investigation when a severe AE occurs. They collect information on the case and check for the reporting among responsible recipients on the same vaccine lot. Municipalities ensure that the epidemiological investigation is carried out properly. Epidemiologic officers visit the medical institution that diagnoses the serious case, review the medical record, and interview the physician, vaccinee, and guardian. They also record the progress and finding in the system. KDCA convenes a rapid investigation committee, including members from the Vaccine Injury Investigation Committee, KDCA, and municipal epidemiological officers and immunization officers. They assess causality between vaccination and the AE. During this process, the committee may decide to seal or record the vaccine lot. An official from the MFDS participate in the meeting to carry out the seal and collection procedure. This slide shows the process example and criteria for vaccine causality assessment, presented in the form of an algorithm. I will explain the National Vaccine Injury Compensation Program. The National Vaccine Injury Compensation Program in Korea was established following an incident in 1994 during a group vaccination of students against the Japanese encephalitis. About 10 children experienced such as dizziness or fainting. An investigation found that this reaction was not caused by vaccine defects or administration errors, but were due to psychological anxiety related to vaccination. This event highlighted the importance of vaccine safety management. So, leading to the establishment of the National Vaccine Injury Compensation Program based on legal basis. Under this program, individuals may receive reimbursement for medical expenses incurred within 5 years from the date of the AE, not a vaccinated date. In case of disability or death, a lump sum compensation is provided. The compensation for death is calculated as 240 months of the national minimum wage. If the AE occurs after a non-national immunization, compensation is provided by kids. This slide shows the status of vaccine injury compensation claims and approval over the past 20 years. The special status 2010 and 2021. In 2010, during the H1N1 influenza pandemic, vaccination was carried out for high-risk group and students first. As a result, many people submitted compensation claims believing that they were affected by the vaccination. In 2022, there were a case of temperature deviation during distribution the seasonal influenza vaccine. The affected lots were recalled and tested, and the result confirmed that vaccine quality was not impacted. However, because this coincided with the COVID-19 pandemic, many citizens concerned about vaccine safety filed a compensation claim. From 1995 to the present, the overall compensation approval rates has been about 53%. In the early years, compensation was more actively granted to prompt public trust in vaccination. Today, with stricter safety review by NIFDS and advancing in medical science, so compensation decisions are based more strongly on medical causality. The most compensation cases are mild AE rather than severe ones. This diagram shows the national vaccine injury compensation system in Korea. Originally, only cases with a medical experience over 300,000 won were eligible for national compensation. However, after the COVID-19 vaccination program, the scope was expanded to include cases under 300,000 won as well. Currently, cases involving less than 300,000 won are reviewed and decided directly by the municipality. Once the municipality noticed the KDCA of the decision, the KDCA provides the compensation to the applicants through the national compensation process. This slide lists the documents required from both the applicants and the public health officials for vaccine injury compensation. Applicants must submit their vaccination history, medical expense receipts, and medical record that can support their causality assessment. In case of death or disability, they must also provide an autopsy report or a disability certificate. Public health center must prepare additional documents needed for the causality investigation, including the national lot release certificate and the biological product release certificate and vaccine temperature law to confirm that no vaccine quality issue occurred. This slide shows the criteria for causality assessment in Korea. It is based on the WHO UMC system and has been adapted into 5 categories. During the preparation for the COVID-19 vaccination program, a new category was introduced for cases classified as indeterminate in the red box. This category applies when there is a temporal relationship between vaccination and the AE, but insufficient evidence to prove causality. In such a case, medical expenses are still supported in Korea, especially for COVID-19, not a NIP. Typical examples include Guillain-Barré syndrome or Bell palsy after COVID-19 vaccination. This slide is taken from the training material for National Immunization Program officers. It shows the application screen used by public health center staff when submitting a compensation claim over 300,000 won. On this screen, the officer enters all necessary information, including the vaccinee's detailed disease type as code, ICD code, and the type of compensation for disability or death. It also covers whether it is a first application, and or one-time appeal, or an additional compensation request in case where causality has been recognized. This screen shows the progress status of the compensation application. This screen allows us to check whether the case is an initial application or an appeal, the type of compensation requested, the current stage of the review process. On the right square, there is a section where KDCA entered the final compensation decision. This screen is used for entering cases involving small amount compensation. As I said, under 300,000 won. So once the review is completed at the municipal level, case is entered into the system. KDCA then provides the compensation payment and record the outcome, after which cases involving small amount compensation are closed. The result. This concludes my presentation on the immunization safety management system operated by KDCA. The contents so far were jointly prepared by the KDCA and MFDS as the preparation for the WHO GBT assessment. Next, I will describe what took place during the WHO on-site review, and the experience with the PE reflects my personal opinion. As previous speaker said, the review team request to visit municipalities and public health centers to verify the actual implement of vaccination safety management. Therefore, they visited Sejong City and the Sejong Public Health Care Center, which are located near the KDCA. For the WHO review, each institution provides an overview of its key responsibility, including introduction to the department in charge of immunization and their specific roles. This slide presents information on the safety management of COVID-19 vaccination. Especially in addition to what I mentioned, the management earlier, municipalities operate rapid response teams that include external clinical experts when a severe AE occurs. In the red square. This structure enables timely and coordinated response at the local level. For example, if a death is reported following COVID-19 vaccination, the municipal rapid response team is activated to conduct the initial causality assessment. If the initial assessment suggests a possible causal association, the KDCA convenes a rapid response meeting to conduct a more detailed causality investigation. At KDCA, the definition of a severe AE generally includes anaphylaxis, severe neurological symptoms, life-threatening condition, and other events that are recognized as equivalent in severity by the expert committee. Therefore, conditions such as TTS, myocarditis, and pericarditis were classified as severe AE after COVID-19 vaccination, and the rapid response teams were activated accordingly. It is my opinion. The review team verified that all of the procedures described in the GBT written responses were indeed being implemented in practice, and they confirmed the supporting evidence for each step. Accordingly, the review teams examined the committee's meeting materials and decision paper, epidemiological investigation reports, and the documents and experience from COVID-19 vaccination meetings conducted by municipalities. They also assessed the actual vaccination site in public health center, including vaccine storage practice, the layout for post-vaccination observation area for 15 to 30 minutes, patient flow after vaccination, and whether any vaccination error had occurred. Since all reports submitted by local government were already entered into the system, we reviewed the actual workflow by assessing the system and observing how its responsible officer used it in practice. We also reviewed the informational materials on vaccination safety, as well as the documents detailed the response procedure in case of AE. In Korea, most of the vaccines are administered through the NIP. Therefore, vaccine safety data are collected by the KDCA. The reported AE information is shared with the MFDAs through quarterly coordinating meetings. In addition, the MFDS and KDCA joint developed an AE responsible manual and have been coordinated responses together. As an example, the response to the influenza vaccine cold chain temperature deviation incident, which I mentioned earlier, was documented and released as an official press statement. In addition, all vaccination officers are required to complete training before the annual immunization program begins. As a result, the staff members have a high level of understanding of their responsibility, and they are able to carry out their task accurately using the manual and information system without operational errors. These are the actual documents we prepared for the WHO inspection. That is all I have prepared for today. Thank you for your attention.